for agreeing to do this, and it's, of course, a part of our Juneteenth celebration. And then, sorry, let me let this person in the room. To start us off, we have Dr. Elton Lambert. I've known Dr. Lambert since he was a young man, fresh out of fellowship. And I've taken an interest in him because, you know, there's not a lot of Black folks here in Texas, and particularly pediatric otolaryngologists. I think there's just two of, no, is there three? I think there's just two, and so Dr. Lambert, he's at our rival institution. So I also keeping tabs so I can know what the competition is doing. He's at Texas Children's, and he did his residency at Iowa, I believe, Iowa, right? And then your fellowship
in Iowa, and then UT Houston for.
He did his residency at McGovern Medical School in Houston, Texas,
and
he had
fellowship at Iowa.
Yes, Dr. Rondra, she's claiming me appropriately.
And he's gonna give us a pediatric otolaryngology potpourri, and so I'm gonna turn over the discussion to him. Thank you again so much for doing this.
Yeah. All right. Thanks, everyone. Just want to confirm you can hear me okay, and then you can see my screen. So thanks. Thanks, Dr. Romaine Johnson, for the opportunity to talk about this today. And thank you all for attending. So I was asked to talk about pediatric otolaryngology potpourri. As Dr. Johnson said, at Texas Children's, assistant professor there. So when I thought about like what could be a good sort of unifying topic, multiple surgeries, especially multi-level surgery in a difficult patient population, you know, this is like the typical population or typical patient that I start thinking about. I have no disclosures. So case study is 4-year-old male, snoring, associated gasping, has some daytime sleepiness and restless sleep. Had a TNA by you at age 2, BMI is 18, and family comes to you and says, I thought you said that taking out the tonsils was going to take care of all the sleeping issues, snoring, gasping for things like that. And as surgeons, you know, this isn't necessarily like the home run after our procedure, but this patient still needs care. So for ENT potpourri, they fit into multi-level surgery. My talk today is going to be on persistent pediatric obstructive sleep apnea. So my outline, I'm going to go through it in the next like 20 to 25 minutes. It's going to be a broad overview. Definitely each one of these bullet points can be its own hour-long talk, own instructor course. So we're going to talk about the impact of persistent obstructive sleep apnea, the workup for persistent obstructive sleep apnea, and then level of airway-specific treatment of pediatric obstructive sleep apnea. So how big of a problem is this? So yeah, when I was looking through the literature, like there are some papers that do talk about 33% of our patients will have OSA after a TNA. We may not quote 33%, but that is what's out there in the literature. And just a reminder, persistent OSA can lead to decreased quality of life, impaired neurocognitive development, behavioral problems, and definitely can have a negative impact on the family. So just gonna get my laser pointer up here. And then when we think about what do you do after you take the tonsils out, then that's when you start to have to turn on your basic anatomy brain and where else could things be coming from. So nasal cavity, septal deviations, turbinate hypertrophy, nasopharynx adenoids, maxillary hypoplasia, and then sort of your bang for your buck for persistent obstructive sleep apnea, pharyngeal issues with gladder wall collapse, tongue-based issues, lingual tonsils, macroglossia, glossoptosis, especially in our Down syndrome population, macrognathy, retrognathy in our Pierre-Robin sequence patients, epiglottic collapse, and laryngomalacia. So where do you start? So one of the things to start with is like, when you're going to go in and do a TNA, what are your kids who you're even thinking may be at high risk for post-TNA obstructive sleep apnea? And there are a few societies that have guidelines. So the AAP recommends that your high-risk children who already have a normal baseline sleep study, you probably post-TNA want to refer them or re-refer them for obstructive, for a sleep study. Your obese kids, your Down syndrome kids, a slide later highlights your patient population. The Sleep Medicine Society also says that especially kids who have moderate OSA, obesity, craniofacial abnormalities probably need to follow them more closely. The European Respiratory Society also says that any kid who has persistent symptoms after a TNA should be evaluated with a sleep study. So when you find a child who has some residual obstructive sleep apnea after adenotonsillectomy, definitely want to categorize it based on the severity. So your mild kids can probably start with intranasal steroids, asterisk Montelukast as well, although Montelukast does have a black box warning for teenagers, which should be discussed with patients. Weight management if obese, and that carries all along the moderate severe. You can always start with medical therapy or pressure therapy, but definitely secondary surgical intervention, and in select patients, tracheostomy would be the way to go. So your risk factors for persistent obstructive sleep apnea include Down syndrome, neuromuscular disease, the broad range, going from your cerebral palsy kids, your kids who have hypotonia, genetic diseases, chromosomal disorders, things of that nature. That is not to say, and oftentimes I will screen my neuromuscular kids with a sleep endoscopy at the time of a primary TNA, but not all of these children are going to have persistent OSA, but definitely you want to recognize the kids who may have an issue afterwards, so you can kind of prepare for that. Obesity, craniofacial disorders, Crouzon's, Apert syndrome. There's all these like craniofacial associations where like we're just not as trained as well as the dentists or surgeons are, but definitely things like maxillary retrusion, retrognathia, primary nasopharyngeal stenosis, where all these craniofacial disorders may have that anatomy should be sought. And then metabolic disorders such as mucopolysaccharidosis, your Hurlers and your Hunter kids. So once you get your sleep study, and definitely any child who has any persistent sleep symptoms, by practice patterns, maybe you're going off of symptoms for primary tonsillectomy and adenoidectomy, but when you're starting to get to the recurrent symptoms, then you start thinking like there are kids who have pediatric restless leg syndrome, those who have central sleep apnea, like for your recurrent or persistent sleep apnea kids, like a sleep study is definitely one of the first steps. Drug-induced sleep endoscopy. So although cine MRI is described, I haven't been at an institution where it's been widely used. And maybe someone on the call can speak to their use of cine MRI at their institution, but through residency fellowship here, I haven't just been at an institution where we're using that regularly in children. So sleep endoscopy, medication-induced sleep. Usually we want to avoid the inhalant anesthetics and propofol because you lose most of your tone with these agents. And so it is going to be, you may get these false positives if these are on board. Many institutions have talked about their dexmedetomidine and ketamine cocktails to try and induce sleep without getting your massive amount of upper airway collapsibility that may not give you a correct idea of what's going on. So here, looking at we will look at the inferior turbinates, the adenoids to see if there's any residual adenoids, palatal collapse, oropharynx. If you are doing a partial tonsillectomy, you may notice some residual tonsils, epiglottic collapse, lingual tonsils, definitely, and then primary at the area to look for laryngomalacia. So in order to make good decision making, and this is something I've done more and more over the years, good decision making, as well as later for research studies, some sort of scoring system or a organized way to document your DISE, drug-induced sleep endoscopy findings, is typically advisable. So you have the SIRS, the sleep endoscopy reporting system, which talks about nasal area all the way to the hypopharynx, as well as these studies that talked about their scoring systems at our institution and becoming more widely used. It has been published widely in the adult literature and starting to be used and published about in the pediatric literature is both the velum, oropharynx, tongue base, and epiglottic airway. Here, there is a note of the nasopharynx airway, but once again, a lot of the difficulty comes from the velum, palate, oropharynx, tongue base, etc., and the epiglottis, and noting whether there's no obstruction, partial obstruction, and complete obstruction. And for the palate, the pattern of obstruction is important. Any child who has concentric obstruction at the level of the palate, they have a very poor likelihood of having any improvement in in a lot of the surgical any surgical techniques because of that. It can be a sign of hypotonia. But that's something that definitely you want to note in a very systematic way to track outcomes. So by each portion of the airway, nasal airway, looking to see if there's any inferior turbinate hypertrophy, residual adenoids, no adenoids versus complete obstruction of your adenoids. At your palate, looking at collapse, whether it be fully open, partially open, or complete collapse. And then this is the notation of the vote system, looking at the lateral pharyngeal walls and the pharyngeal walls in general, the level of obstruction there. Tongue base, and specifically how much of the vallecula you can see, and then the lingual tonsillectomy, it's figuring out what your extent of resection should be based on whether you can see the vallecula or not. Epiglottis, looking to see if there's any epiglottic collapse, any afold and arytenoid collapse, so you can diagnose sleep-induced laryngomalacia. So this is a patient that I actually did a few weeks ago. So he had severe inferior turbinate hypertrophy, made a pit stop at the nasal pharynx, which was good, oropharynx, palate looked great. Had significant lingual tonsil hypertrophy with near complete touching of the epiglottis to the posterior pharyngeal wall. At some point here, we're going to see a jaw thrust, seeing what that does, and had some respiratory effort, and he did not have any sleep-induced laryngomalacia. So turbinate reduction in children, we're going to do a broad survey of the various levels. In children, submucous reduction can be done with a collator or microdebrider assisted. At some point, I just feel like in kids, especially age 12 and 0, it's very difficult to get a microdebrider into the turbinates. There's no specific studies on the contribution of IT reduction in persistent OSA, but also always something you want to keep in mind. With respect to techniques, this is a study from a study looking at the treatment of inferior turbinate hypertrophy, either by submucous resection or through reduction of the inferior turbinates. And the two over time seem to be pretty close in the post-operative look. Now, there's no objective findings of the rhinomanometry or acoustic rhinometry, but as far as I'm concerned, it seems to be just like what instruments can you use, and definitely coblation is a good way to manage these patients. Palate surgery can range from doing lateral pharyngoplasties where you're just suturing the pillars together, where you decrease your collapsibility. Your classic UPPP, resecting the portions of the soft palate and the uvula, especially in patients who have an elongated uvula. And then expansion sphincter pharyngoplasty. These are a couple pictures showing the technique for a expansion sphincteroplasty. This can be done either post-tonsillectomy or the tonsillectomy. Really, the goal is to isolate the palatopharyngeus muscle associated with the posterior pillar, dissecting the muscle, and then there are multiple descriptions of how this is rotated into the superior pillar. There are techniques for using a horizontal mantris into the hamlet of the pterygoid plate associated with the palate. But you're really trying to just expand your oropharyngeal airway in that way after noticing some palatal collapse. Lingual tonsil hypertrophy is one of the most common. I almost feel like even preoperatively, even post knowing that a patient's going to need a lingual tonsil reduction. This is the same intraoral photos from the same patient with the sleep endoscopy. And really, as surgeons, we're trying to kind of go back to original anatomy or more favorable anatomy. And I always think about using the coblator. You're just trying to give the child a reasonable vallecula, just somewhere for the epiglottis to go. I feel every single time I've gone a little bit too deep and you're starting to get into midline glossectomy territory, that's when I've gotten into trouble from more postoperative edema or postoperative bleed. And it feels if using the deep portion of the tongue has always served me well. Systematic reviews have shown that you can get decreased AHIs consistently in patients who present post-tonsillectomy who have OSA, and it works really well with anywhere from a 5 to 20 point reduction in your AHI. Some patients have sleep-induced laryngomalacia. This patient actually had a supraglottoplasty before with 1+ tonsils, had some scarring, and re-presented with post-op laryngomalacia, and then post-op scarring leading to recurrent laryngomalacia, and then we did a revision. And with your supraglottoplasties, there are these systems where you can go type 1, type 2, type 3, but ultimately, thinking about your anatomy, what you're trying to correct, your bulky retinoids need a retinoid reduction. You don't necessarily need to have a fold release. Your kids who have predominantly A-fold reduction, A-fold tightening. They can have A-fold clipping, some combination of the two. For kids who have primarily epiglottic collapse, some roughing up of the laryngeal or the lingual surface, and then placing sutures or not. This picture is showing suture placement. This picture is showing just attempting by sparring. This is a picture from this paper thinking about sometimes your superior epiglottis is just a little bit too weighty, so resecting it can often help. I've never done that before, but oftentimes these other procedures seem to do pretty well. Just like with lingual tonsils, if you diagnose the level of the obstruction, you will get a good result with consistent decrease in AHI after sleep-induced supraglottoplasty to treat your sleep-induced laryngomalacia. Yeah, sometimes even before a patient is going to sleep, like if you hear them being induced, and if you're hearing stridor even while the child is going off to sleep, oftentimes that's a good indication of like some sleep-induced laryngomalacia or lingual tonsil hypertrophy so bad that you're getting some epiglottic collapse, which was the case in the case I showed you earlier. So overall, to have a summary of studies for DICE, so thinking where you're going to notice some of these areas for obstruction: residual tonsils, tongue-based, adenotonsillar. You can have residual tonsil tissue. Velum is always and can be an issue, tongue-based lingual. But sort of the things I'm always going in and looking for are oftentimes it's very much lingual tonsils, and some kids may have some velar issues as well. So take-home points: subset of kids that need more than the TNA to treat their OSA. Patients with signs of OSA post-TNA, I think it's always a great idea to start with a sleep study, even if you may not have gone to a sleep study pre-op TNA. Sleep endoscopy can identify areas of obstruction, and then continued surgical treatment can be based on level of obstruction. Not within the scope of the talk or CPAP discussions, and definitely exciting news about the indications for technologies such as the hypoglossal nerve stimulator, especially in a lot of our Down syndrome kids, as some sites are currently studying. And thank you for.
Thank you. Do you want to stop sharing your screen? Thanks, Dr. Lambert. I have a couple of questions. If anybody else has any questions, you can put them in the chat, or you can raise a hand. I'll get to you. So one question I have is, do you think we should be routinely doing DICE on high-risk patients at the time of their TNA?
I think for our high-risk patients, I have. It's one of these things whereby this is my opinion, and but I do think you can set yourself up. And I think one of the things that I've found it helpful for is like post-op counseling, whereas routinely my cerebral palsy population, especially, like I go and kind of say, well, I don't know if this is going to work, but then like I've kind of looked and expecting your classic like circumferential collapse in a lot of CP kids, and I don't see it. And I go in and say, you know what? I think it's the tonsils driving this. I think we're going to be okay. Or you see the circumferential collapse and you go, and then like you can tell families like, okay, then I think it's a good idea for us to, I think there's a possibility that like this won't be the end of it. The other routine are these kids. There is like an old study that's buried in the literature that nobody talks about, and the fact that, you know, like any child who has an AHI over 20, they are at a higher risk of post-op TNA obstructive sleep apnea. Those kids as well, oftentimes I will, and it's really for your like post-op planning and like next steps. To think like, okay, I already know they have big lingual tonsils. When they come back, maybe they won't have any symptoms. So, or the post-op sleep at post TNA sleep study looks okay, then they're good. Or sometimes the other finding that's very hard to parse out is like your sleep endoscopy, laryngomalacia, especially arytenoid prolapse. Some kids are sucking in so much past their tonsils. That's what's driving in the arytenoid prolapse. And then they come back and they say, they might need a supraglottoplasty afterwards. And then they say, no, it's good. And you don't need. So I think, I think to answer your question, I think in the high-risk kids, it's useful, but like sometimes I'm more of a future planner. What am I going to tell this family when I think it's not going to work? I think that's what I'm using it for, especially.
And then are you guys starting to look at the hypoglossal nerve?
So I mean, I think so. You know, Mary Musa, one of my partners, I think she has been trying to get it as an approved site at this point for years. And like, I think, it's one of these things where like with COVID, we were about to be a site and then COVID wasn't able to, but.
We finally got it approved here in Dallas, and apparently they got a couple of kids lined up, but they're like the Down syndrome type kids. So I was just curious. Okay.
Yeah.
All right. Well, guys, thank you so much, man. That was awesome. I really appreciate it.